All right, welcome to the Explainer. Today, we're going to tackle one of the most common diagnostic challenges you'll ever face, anemia. We're going to build a solid, actionable blueprint, a framework you can start using like tomorrow on the wards. Anemia. Seriously, where do you even begin? It's everywhere in clinical practice, right? So today, we're going to build a really solid mental model, a step-by-step approach that you can use every single time to approach this with a lot more confidence. So here's our game plan for this explainer. We'll kick things off with the basics, then build your diagnostic toolkit. We'll look at 3 ways to frame the diagnosis, dive deep into the MCV decision tree, cover the can't miss red flags, and finally, put it all together. All right, let's jump right in. First things first, to tackle any problem, you gotta know what you're looking for. And in medicine, that means starting with a really clear, measurable definition. Okay, so on the surface, this seems pretty straightforward, a drop in red blood cells. But the key, the real key, is knowing the specific numbers, the exact cutoffs that take a low lab value and turn it into an official diagnosis. And here they are. These are the World Health Organization's numbers, and they're your bedrock. For non-pregnant women, it's a hemoglobin less than 12. For men, less than 13. Seriously, burn these numbers into your brain. But, always remember, they're a guide. Your clinical judgment is still king. And yeah, this is not some rare thing we're talking about. It's a huge global issue. And if you look at the causes, they fall into 3 kind of equal buckets. About a third is from nutritional stuff, like iron deficiency. Another third is from chronic diseases. And then there's this last third, the unexplained or other bucket. That's often where you find more serious things like bone marrow problems, especially as people get older. Okay, so now that we know what we're looking for, let's put together our diagnostic toolkit. These are the essential lab values, the things you'll pull from the CBC that are going to guide your whole investigation. And the first tool you're going to reach for pretty much every time is the MCV, the mean corpuscular volume. I want you to think of this as the first big fork in the road in your diagnostic journey. It's your initial clue. Are the cells too small, too big, or are they, just right? Next up in the toolkit is the reticulocyte count. And this one answers a super important question. Is the bone marrow factory doing its job? Think about it. If you're anemic, that factory should be working overtime, pumping out new baby red blood cells, reticulocytes, to compensate. If it's not, well then maybe the factory itself is the problem. Okay, toolkit's ready. So now let's talk about the mindset. There are really 3 powerful lenses. 3 different ways you can look at any patient with anemia to figure out what's going on. So you've got the clinical picture. You're looking for red flags on the CBC, and you're using the MCV. Now, an experienced doc, they're juggling all 3 of these at once, almost without thinking. But for you, as you're building your skills, the most solid, reliable place to start, it's that MCV classification. It gives you a clear path forward. All right, here we go. This is the heart of the whole approach. We're going to walk down this MCV decision tree step by step, and we'll start with that first branch. What happens when the red blood cells are too small? That's what we call microcytic anemia. So you get the labs back, and the MCV is low, let's say under 80. Your brain should immediately go to one place. There's a problem making hemoglobin. And in that world, there are 2 giants, 2 main culprits you have to think about first every single time: iron deficiency and thalassemia. And check this out. This is such a cool clinical pearl. It's called the Menser Index. It's a super simple calculation you can do right there with the CBC results. You just take the MCV and divide it by the red blood cell count. If that number is less than 13, it starts to point you away from simple iron deficiency and makes you think a little bit more about thalassemia. It's an awesome little trick. Okay, so what if we go down the other path? What if the cells are big? We're talking an MCV over 100. Well, your whole thought process has to shift. Now we're thinking about issues with DNA synthesis. B12 and folate are the big ones here. But you also have to think about other things like alcohol use, liver disease, certain meds. Even a high retic count can do it, because those baby red cells are just naturally bigger. All right, now for the tricky one, normocytic anemia. This is when the MCV is right in the middle, totally normal. And here's the kicker. This is the most common type you'll see, and honestly, it's often the hardest to figure out. This is where you really have to put on your detective hat. And the reason it's so tricky is that the differential diagnosis is just Huge. It could be something like anemia of chronic disease or kidney disease. It could be a nutrient deficiency that's just starting out before the cell sizes had time to change. Or, and this is a classic trap, it could be two problems at once. Imagine someone has both iron deficiency, which makes cells small, and a folate deficiency, which makes them big. They can cancel each other out, and you end up with a normal MCV. Tricky, right?
Okay, this is super important. A huge part of any good blueprint is knowing when to stop, when to recognize that this isn't just a routine case. There are certain findings, absolute red flags, that mean you need to act fast and get some help from a specialist.
And here's the biggest one. If you see anemia and low white cells and low platelets, you stop. Everything stops. That's pancytopenia, and you have to treat it like a hematologic emergency until you can prove it's not. It screams that something is seriously wrong with the bone marrow.
So here's your checklist for when to call hematology. Seriously. Severe pancytopenia, seeing weird immature cells or blasts on the smear, or seeing broken red cells called schistocytes. Any of these are an immediate phone call. And you know what? Even if you've done the initial workup and you're still scratching your head, that's a perfectly good reason to refer. Don't hesitate. All right, let's wrap this all up. We're going to pull all these pieces together into one final, easy-to-remember blueprint that you can use to really master the anemia workup. This is it. This is your system. Step 1, start with the CBC, confirm the anemia is real. Step 2, categorize it immediately using the MCV. Step 3, check the reticulocount to see if the bone marrow is responding. Step 4, always integrate the whole clinical picture. And step 5, keep an eye out for those red flags. If you follow this process, you will systematically and logically work through the problem every single time. So next time you're on rounds and your attending asks, your patient's hemoglobin is 10, what's your first move? You're not going to freeze. You're going to have a framework. You're going to have a plan. You'll be ready to move past the uncertainty and take that first step with confidence.